Good evening, everyone. So, today I'll be taking a small presentation on spontaneous intracerebral hemorrhage. So, out of all the strokes, the ischemic ones they form a separate class altogether. The hemorrhagic ones they are classified a separate class altogether. And as soon as a patient with a sudden onset neurological deficit arrive at a hospital, the first and the foremost thing that you have to do is you have to do a immediate neuroimaging, a NCCT head, and that is how you classified the strokes into a acute ischemic one and a hemorrhagic one. So subsequent to that, today we are here only to discuss about spontaneous intracerebral hemorrhage. So the burden of India has been increasing over the last 1 decade. The increase has been shown to be around 10%, and the increase is because of increase in the number of hypertensives in our country. The present prevalence is around 26 per 100,000 population, and as you know, our country has got a very limited tertiary care facilities, and so majority of these cases presents to a level 1 or a level 2 care facility. So what is the etiology of ICH? The predominant etiologies remains primary hypertension, which causes the rupture of the small penetrating artery within the brain matter. Secondly, coagulopathies, which may be drug induced because the patients are on anticoagulations because of either a valvular heart disorder or because of DVT, they lands up with ICH. Moreover, in our scenario, we have got viral hemorrhagic fevers like dengue, which causes thrombocytopenia, coagulopathies leading to ICH. Cerebral amyloid angiopathy in elderlies, they causes lower hemorrhages, multifocal in nature, and of course the vascular malformations. So the clinical presentation is just like any other stroke. However, the onset of the neurological deficit is more sudden than the ischemic one, because in ischemic one there is an infarcted area and the infarcted area gradually progresses over a period of time. But however, in this there is a bleed and subsequently the disorder may progress. It is associated with altered level of consciousness, the other symptoms of features of raised ICP like headache, vomiting and seizures. So features in NCCT head that you find are hyperdense areas. These white looking areas on a non-contrast CT scan of brain is called a hyperdense area. And apart from the hyperdense area, what are you supposed to look for? You are supposed to look for the mass effect. The mass effect because of the sudden occurrence of hematoma within the brain matter. And then there is the edema around, which keeps on developing till the increases till the 5th to 6th day, and then it gradually decreases. And the extension of this hemorrhage into this ventricles, these are the ventricles. So this is the third ventricle. Then you have to see whether the blood is in the frontal horn or in the occipital horn, or is there any blood in the ventricles. So hematoma is basically, if you see at the brain matter, it is classified into a supratentorial, the tentorial cerebelli, which demarcates the cerebrum from the cerebellum. Okay, so anything which is below the tentorium cerebelli is called as subtentorial hematoma, and anything that is above the tentorium cerebri is called a supratentorial one. And according to the size, generally a size which is greater than 30 ml in the supratentorial region is considered a large hematoma, and less and greater than 15 ml size in a subtentorial one will be called a large hematoma. Because this subtentorial part, you have to understand, it is a very compact structure in the posterior fossa where every white vital organ like the brainstem, the cerebellum, everything lies in close proximity to one another, and even a slight increase in the mass will press the brainstem against the calvaria. So as I told you that in the imaging finding you will have a hyperdense area. This so you may get a question that what are the commonest site of a hematoma in hypertensive males, in hypertensive individuals. So the commonest site is the basal ganglia. The basal ganglia accounts for around 50%. Then subsequent to the basal ganglia, the second most commonest place is the thalamus. From thalamus, more we move on to the brainstem, and brainstem down below the cerebellum. The brainstem and the cerebellum accounts for around 10% each of the spontaneous ICHs. So if you see, there is a hyperdense area. So hyperdense area. So what are the other hyperdense areas that you find in a NCCT? The other hyperdense areas are the normal physiological areas of calcification, which you can find in a normal NCCT near the brain parenchyma. So what are the physiological areas of calcification? One is fox cerebri. The second is pineal gland. Third, basal ganglia. Fourth, choroid plexus. And fifth is tentorium cerebri. In elderlies, you can find also calcification in the lens matter. So there might be a calcification over here, and this thing that you see are the choroid plexus which is got calcified. So if you see anything in the ventricle, don't jump to the conclusion that there has been a intraventricular extension. So if you look at the brain parenchyma, the brain is divided into the white matter and gray matter, and this that you see, this area, this is the junction between the gray matter and the white matter. So this white matter, it has got the hyper density in a NCCT head. It is measured in terms of HUs, Hounstones, HU units. So HU units of the bone is generally around 700 to 3000 HUs, and this area that you see is around 20 to 30 HU, and over here it is 40 HU. And a bleed has nearly got a HU of around 50 to 80 HU. So, and it appears hyperdense. So, and this is what you see. This is the individual has undergone a CT angiobrain. So CT angiobrain shows what? There is a small white dot you see over here. This is the spot sign. This is the bleeder. So appearance of a bleeder in a NCCT means कि it has got a propensity to bleed. There is a propensity for increase of size of hematoma. So you have to understand that there is a fight which is going on within the closed space, within the closed calvaria, between two things. One, the blood pressure of the individual causing an effect of increase of hematoma, and the tamponade, vascular tamponade effect of the hematoma in a closed space causing, or it is trying to shrink that hematoma. So there is a fight between these two forces which is taking place. So whenever you get a CT scan, you have to look for certain features which are more predictors of increase of size of hematoma. So this, if you see, this is a irregularly shaped hematoma. Irregularly shaped hematoma, the size may increase. Then over here, if you see, there are greater than 3 areas of hyperdensity, which is located out from the initial area. A big hyperdense lesion, and there are 3 areas. So this is again suggestive of an increase of size of hematoma. Third is heterogeneous texture of the hematoma. You look here, this is hyperdense, this is slightly less hyperdense, and this is another hyperdense lesion. The appearance of hypodensities in the structured hematoma is once again a sign that there will be increase in the size of hematoma. Then over here, if you see that when there is a difference of greater than 30 HU in the single lobar bleed, then you may again consider that there is a significant chance that this hematoma will expand. So for such patients, you have to be extra careful and an extra monitoring should be taking place. So then coming again to this mass effect that we are talking about, the effect that occurs because of three different reasons. One is the size of the hematoma itself. Then subsequently, because of the hematoma, there is a pressure which builds up, which tries to push the normal brain matter out from its original location. And then the edema surrounding the brain matter does the same thing. And then if there is a chance of hematoma expansion, it will further push the brain matter out from its original place. So how this can be there are various different types of herniation that we call the displacement of the brain matter from its original location. If you remember, this is the fox cerebri. Okay, this place is the fox cerebri. So any herniation that takes place from one side of the cerebrum to the other side in a subfalcine region will be called the subfalcine herniation. And over here, what you have got? You have got the foramen magnum, through which the medulla oblongata gets converted into our spinal cord, and over here the cerebellum may herniate. The cerebellum and the vital structures of the brain, that is the brainstem, may herniate, and this is called the tonsillar herniation. This is called the tonsillar herniation. Then there are other types of herniation which occurs through the tent. This is the tentorium cerebri. So this is called the tentorial herniation. And then there is of course the central herniation. So how do you monitor such patients, and how does a herniation progress? Herniation progress by alteration of consciousness, the Cushing triad, in which there is a increase of BP and decrease of heart rate. Initially the pupils will become anisochoric, the ipsilateral pupils will dilate, and then subsequently the contralateral pupil will dilate. So ipsilateral dilatation of the pupil will be the initial signs of herniation, whereas the contralateral dilatation is a very late sign of dilation, which also means that the other brainstem reflexes by that time will go absent. Then there will be decerebrate posturing. So what are the managements of acute cerebral hemorrhage? So we have already discussed about the burden, the etiologies, the clinical manifestation, and NCCT findings, and how to monitor a patient, or how we corroborate the patients clinically with herniation, how to monitor such patients for herniation. So what is the initial management of acute cerebral hemorrhage? The initial management of acute cerebral hemorrhage is basically based on hematoma stabilization. This forms the cornerstones. As I told you that there has not been many advances in management of spontaneous intracerebral hemorrhage. So the first and the foremost thing that you should keep in mind is to stabilize the hematoma, prevent the hematoma from expansion. It is the first and the foremost focus of any physician managing a case of intracerebral hemorrhage. Then subsequent to that is focus on blood pressure control, intracerebral pressure, and then what are the preventive measures for managing complication. So why is there a elevated ICP in a hematoma? Because of the mass effect, that is the hematoma itself causing the pressure, as I have told you. Then there is the expansion of this hematoma. Then there is increased edema around this structure, the edema per se, and then there is obstruction when the blood is there, when the this thing already presses on the aqueduct sylvius directly, or there is intraventricular extension causing a clot formation in the aqueduct or in the route of the flow of the CSF. So it will lead to dilation of the ventricles, and that is how there will be increased in the ICP. So is there a role of surgical intervention? Oh yes, there is a role in a very few selected patients, and those patients you have to identify who will benefit from a surgical intervention. And you have to understand one thing, that the benefit is maximum only when it is done within the 6 hours of onset of the symptoms. Less than 6 hours, the benefit is the maximum. So what kind of a spontaneous intracerebral hemorrhage that you should refer for a neurosurgical intervention? The cerebellar hemorrhage, because this is the posterior fossa, as I told you, is a very confined space with a very limited capabilities of expansion or controlling the ICP. There is a tentorium cerebri over here, there is a foramen magnum over here. If you don't control it, either this will press the brainstem ahead, causing the compression of the vital structure of the brainstem, or it will herniate through the foramen magnum. So any hemorrhage which is greater than 3 centimeter associated with neurological deterioration, brainstem compression, or hydrocephalus has to be operated. So cerebral hemorrhages undergo decompressive hemicraniectomy either prophylactically, or you have to monitor them very stringently. The second thing is intraventricular hemorrhage. As I told you, the CSF has got a very specific path within the calvaria. So there are the lateral ventricles, the third ventricle, the fourth ventricle. So if there is a blockage over here, it will cause the dilatation of the ventricles above it. So in case there is a clot which has formed over here, you can, what we prefer to do is we put in a drain to any of these ventricles, and we perform something known as EVD, and external ventricular drainage, so as to ease out the pressure of the within the calvaria. Then in cases of supratentorial hemorrhage, the indications are not that clear. However, a bleed which is located within 1 centimeter from the surface, causing compression of the vital structures, decreased sensorium, will be amenable for early neurosurgical intervention. So coming to the point of blood pressure management, so you have to achieve, the American Heart Association says you have to achieve the blood pressure management as early as possible. So in case a person has come with a systolic blood pressure of 150 by 220, please lower the systolic blood pressure to less than 140 within the first 1 hour. If you do it, you will stabilize the hematoma. There will be no further bleeding. For the systolic blood pressure which has been recorded to be greater than 220, lower the SBP to less than 220, and then gradually reduce it to 140 to 160 milligram over hours. Why is it so? Because sudden decrease in the blood pressure may lead to decreased flow of blood in the brain and may increase the size of the brain damage. So the only targetable thing, because this is the majority, the class of the patient will be within 150 to 220. So please lower the BP, systolic BP to 140 as soon as possible. So role of decongestive therapy, oh yes, it should be initiated as early as possible. The decongestive therapy that is predominantly used in mannitol is mannitol. So mannitol is available in 20%. So how much is to be used? What is the initial dose of mannitol that you think should be given to a patient? The AHA recommends that the initial dose is to be 1 gram per kg, subsequent to be followed with 0.25 to 0.5 grams per kg every 8 hourly. So the first gram approximately for a 60 kg person will be around 300 ml, and this again if you calculate it boils down to around 100 to 200 ml every 8 hourly. Role of hypertonic saline, very appreciable in controlling raised ICP. So what should be the target? You can give around 15 to 30 ml of 21% saline every 8 hourly. Maintain a serum sodium greater than 145 and less than 155 MEQ per liter. So the general care is maintain the head elevated to 30 degrees. This will bring down the ICP. Use sedation, prevent agitation. Maintain a Richmond agitation sedation score of 0 to -2. Judicious use of antipyretic in management of fever, and use it to keep the temperature less than 38 degrees centigrade. And do not use hypotonic saline, because the hypotonic saline may cause increase in the cerebral edema. So always use isotonic saline or normal saline for maintenance and replacement fluids. So additional measures is prevention of aspiration. Keep the patient NPO until and unless you are very sure that his swallowing reflex is this thing. Insert a Ryle's tube. Prevention of venous thromboembolism. So how do you prevent a venous thromboembolism in a patient who has already bled in the brain? Use DVT pumps. LMWH can be initiated after 48 hours. Use of alpha matrices, ear matrices to prevent skin breakdown and from pressure. Do not let the patient get dehydrated. Use judicious use of isotonic solutions only. I prefer not to use dextrose solutions. I do not use any hypotonic solutions. Fever management. Fever has shown to have increased mortality and delirious effects on the individual. Hence, by judicious use of antipyretics like paracetamol, please keep the temperature below 38 degree centigrade. Glucose management. Keep the blood glucose within a safe range, and you should individualize it for every individual. Though people don't use gastric acid suppression, or we don't use gastric acid suppression routinely just to prevent complications like aspiration pneumonia, but gastric acid suppression is recommended for patients on invasive mechanical ventilations or patients who have undergone neurosurgery. Only for those patients we recommend Otherwise you don't recommend. Okay, now these are the salvage therapy. Despite of your head elevation, temperature management, your giving decongestive therapy, cerebral decongestive therapy, still you find that patient manifests features of increased BP, decreased heart rate. So what are the other solutions that you may try before giving? You have to go all out by then. So hyperventilate the patient. You have to place the patient on invasive mechanical ventilation, hyperventilate, target a PCO2 of 30 to 135 millimeter. Further decrease of PO2 to 15 to 20 centimeters have been detrimental. So the recommended target range of PaCO2 is partial pressure of carbon dioxide is 30 to 35. In some places, in the just for theory purposes, you must remember that there is been a role of barbiturate induced coma or propofol infusions, but those has to be prolonged, and it has come with some amount of morbidity per se, and this is not used that often. Neuromuscular blockade, oh yes, if the patient is not sedated properly, then it will cause further increase in agitation and leading to increased ICP. So you should sedate your patients well. And hypothermia, induced hypothermia, though not much data is available, but it does reduce ICP through decreased cerebral blood flow and metabolism, and may be tried as a salvage therapy. So this is what we have discussed earlier, ki as how does a transtentorial herniation presents. That is firstly increased headache, then secondly followed by altered level of consciousness, dilatation of ipsilateral pupil, third cranial nerve palsy, followed by decerebrate posturing, hemiparesis, hemiplegia will be predominating, then followed by dilatation of the alternate pupils, followed by chain stroke respiration, bradycardia, hypertension, and then finally cardiorespiratory arrest. So these are a few scores which are used to calculate 30 days mortality. So if you see the first score that I like to discuss is the ICH score, and the ICH score has got if you see 5 main component in this, that is this GCS at presentation, the ICH volume, the intraventricular extension, infratentorial origin of the ICH, and age greater than 80 years. So what have they done is they have considered a large volume bleed to be of poor prognosticate, intraventricular extension poor prognostication, infratentorial again poor prognostication, advanced age poor prognostication, and of course a low GCS a poor prognostication. So this is the very simple way of reminding it, and subsequent to that, if a ICH score results from 0 to 6 with higher score being associated with higher mortality. So a 13% mortality for a ICH score of 1, whereas you see 97% mortality with a score of 4 and 100% for a score of 5. So this is how you can predict 30 days mortality at the presentation with this ICH score. And this is a functional score, and which is able to tell you the functional outcome of an individual 90 days after a spontaneous intracerebral hemorrhage. Once again, this has got 5 component. The first component being the ICH volume, the age, the ICH location, GCS at presentation, and pre-ICH cognitive impairment. And this total score is divided into from 0 to 11, and if you see, the favorable outcome was 0% for a func score of 0 to 4, and if you if you see, and there was a 82% if the score was fairly high. So depending upon this, you can again predict what will be the functional outcome of your patient after 90 days of the initial presentation. So with this, we come to the end of the discussion, and just to tell you that a hypertension is a killer disorder, and a poorly, there can be nothing more wrong than a poorly controlled hypertension. So as you see your patients in the OPD, try to bring the patients of hypertension in control, and that is going to improve their outcomes as far as this spontaneous ICH is concerned. So thank you so much.